Good evening to all. Good evening everyone. How are you people doing for your ESIC exam? Yes, good evening, good evening, good evening. Good evening. Kindly share the link to all your friends, those who are preparing for these ESIC exams. So let us start with today's class. Today's class is going to be like a previous year question paper discussion from midwifery and obstetrical nursing. If you have gone through, please go through the previous year question papers. If you have gone through the previous year question papers, you will understand the importance of studying midwifery and obstetrical nursing. Majority of questions came from midwifery and this OBG nursing. So that's why I want all of you to clearly study your concepts. Okay, not only by having the MCQs and just question and answer, that is not going to help you in any ways in competitive exam. Not only for ESIC exam, whatever you are giving, do not by heart. Okay, just if you are studying MCQs, study along with the concepts. Okay, ఒక రోజుకి 100 లైక్ 50 to 100 MCQs చేసినా కూడా సో దాన్ని కాన్సెప్ట్స్తో పాటు చేయండి. సో ఎందుకు ఈ ఆన్సరే కరెక్ట్ అని దాన్ని కాన్సెప్ట్స్ అయితే తెలుసుకొని క్లియర్ చేయండి MCQsని వెన్ యూ ఆర్ డూయింగ్ MCQs. సో దాట్ విల్ బీ హెల్ప్ఫుల్. ఎందుకంటే సేమ్ MCQ అనేది మీకు రేపు ఎగ్జామ్లో రిపీట్ కాదు. సో సేమ్ MCQ విల్ నాట్ బీ రిపీటెడ్ ఇన్ యువర్ ఎగ్జామ్ టుమారో. But from that concept definitely you are going to get MCQs. So that is why I am telling you when you are studying MCQs, study along with the concepts. Okay, yes, good evening Vinita, good evening Sahiba, yes, good evening. So most of you people started answering this. Okay, I'm waiting for those who are, let others also join. Okay, so we'll start with the class. Venkat, good evening. Swati, Bandar, Praveen Kumar, Durga Devi, Jyoti, Ajit, good evening Ajit. Pranita S, good evening you all, good evening. Good evening all. Detachment of placenta for what? Ponturu Bhagyarada is telling detachment of placenta. Okay, so methods of detachment of placenta. Okay, so yes, most of you people have started answering this question. Yes, good evening Vinod Kumar. So okay, now without wasting our time, let us start with today's class. Okay, yes, good evening. Okay, right, so now starting with today's class, is most of you people have rightly answered it. Methods of, yes, Ponturu Bhagyarada, you are right, it is methods of detachment of placenta. Answer A is correct. Yes, you people are correct. Those most of you people have answered it right. Okay, I think your preparation is going in next level. Okay, right, continue the preparation in the same manner. Have that motive, have that consistency, have that motive that yes, I'm going to surely achieve this, I'm going to surely crack this ESIC exam. Okay, for that you need to study, you need to give your 100%, give it your all to this preparation. Forget about yourself till July. No enjoyment, nothing, switch off everything. Okay, come back to your study table, be consistent with your study plan. Okay, I have also given you the study plan. Those who cannot able to prepare your study plan, I have given you the study plan. Go through that study plan. If not, at least prepare your own self study plan. But self study plan is very, very important. Okay, right, as you people have answered it rightly, yes, this is option A is correct. Okay, yes, methods of detachment of placenta. What they're asking, Skulls method and Matthew Duncan method describe. Option A, methods of detachment of placenta. Option B, delivery of presenting part. Option C, ways of presentation of fetus. Option D, ways to monitor fetal heart rate. Okay. Yes, as you people answered, it is option A, methods of detachment of placenta. Okay. Let us see what is this. Okay, let us see what is this Skulls method, what is this Duncan method, right? Placenta topic is very, very important from OBGY. Okay. And my dears, kindly share the video link to your friends who are preparing for this ESIC exam. Okay, so let them also join for the class. Okay, right. So what is the first? Yes, as you people said, Skulls method and Duncan method, these two are methods of separation of placenta. Let us see what are these methods: Skulls method and Duncan method. Okay. Before going to this, understand this image. Before me explaining this Skulls method and Duncan method, understand this image. See, here is an image. This is uterus. Okay, this is uterus, and inside that I have drawn a structure, right? This is placenta. This is your placenta, and this is your uterus, and this is the maternal side of the placenta. You people know, right? Placenta has maternal side and fetal side, right? This is maternal side of placenta. And please remember, maternal side of placenta will be dull always. Okay, dull in color. Okay, maternal side of placenta dull ga untundi chusedaniki. Okay, and this is the shiny, the yellow one which you are seeing here, this one, that is shiny fetal side. Okay, fetal side will be little bit shiny. Okay, because it is covered with the membranes, it is little bit shiny. Okay, shiny fetal side. Okay, right. Understood? So let now see here in Skulls method, what is happening is, Skulls method, see here, let me erase all this so that you people don't confuse. See here, observe carefully. In Skulls method, see, the placenta has separated here. These both are methods of placental separation, right? See the image carefully. Here the placenta is separated here in the center. Okay, but see the edges, both the edges are attached to the uterus, right? Both the edges are still attached to the uterus, but there is separation from the center of the placenta, right? Here the placenta is getting separated from center. So this is, so separation begins at the center. Separation begins at the center of the placenta, and since the separation of the placenta is starting from the center, okay, the bleed will not come out, the blood will not come out, and the blood is not visible. When the bleeding is visible is once the placenta gets completely separated. Okay, even this edges, once the placenta gets completely separated from the uterus, then only bleeding will be visible. Okay, bleeding is visible after complete separation of placenta. Okay, and see here, I said you right, the placenta is getting separated from the center, right? And see here there will be, just behind the placenta, there will be clot formation. Okay, so there is retroplacental clot. retroplacental clot formation in Schultz method. Okay, whereas see the Duncan method now, Duncan method, the separation, see how the placenta is separated here. Here the placenta is separated from one edge. See this edge got separated from the uterus, right? And let me write it down. Okay, in Duncan method, placental separation begins from one edge. That means begin from periphery. Peripheral separation of placenta is seen in case of Duncan method, and see here in Schultz method you will not see the blood, right? Since there is central separation of the placenta, okay, the bleeding is happening behind the uterus. Once the placenta gets completely separated in the Schultz method, then only bleeding will be visible. But here bleeding is immediately visible. Okay, begins with separation. As soon as the placenta gets separated from one edge, immediately bleeding is visible. Okay, immediately the bleeding is visible. Okay, and there is no retroplacental clot. In Schultz method, I said you people, right, there is retroplacental clot formation. Okay, just behind the placenta clot అనేది ఫామ్ అవుతుందని చెప్పాను కదా. So here there is no clot formation, and see, now come to the Schultz method. Schultz method, once the placenta gets completely separated in the uterus, okay, fetal side of the placenta is felt. Fetal side of placenta is felt at vaginal opening, that is vulva. See, again I am telling you, in Schultz method, once the placenta gets separated completely, shiny fetal side అని చెప్పాను కదా, this one, the shiny fetal side appears at the vulva. The vulva is vaginal opening. Okay, shiny fetal side appears at the vulva after complete separation of placenta. Whereas in Duncan method, okay, after complete separation of placenta, maternal side of placenta appears at vulva, appears at vaginal opening or vulva. Okay, so how to know whether it is fetal side or whether it is maternal side? I already told you, right? Fetal side of placenta will be shiny. So yes for shiny, yes for Schultz method. Okay, Schultz method. Similarly, D for dull, D for Duncan method. So in Schultz method, shiny fetal side, shiny side of the placenta will appear at the vulva, that is vaginal opening. Whereas in case of Duncan method, dull maternal side appears at the vaginal opening, right? Can you people tell me which is most common here? Can you people tell me whether Schultz method is more common or Duncan method of placental separation is more common? Which method of separation is more common? Yes? Can you people tell me? Ramaswamy is telling Duncan method. Any other answers? Schultz method. Yes. Maunika, Anusha, Sriruth, yes, you people are right. Schultz method is more common. This is more common, seen in 80% of cases. Remaining 20% of cases, Duncan method is seen. Okay, Schultz, yes, you people are right. Aishwarya, Prasad, Deva, you people are right. Schultz method is more common. Okay, so one thing you need to remember, Schultz method is central separation. Duncan method is peripheral separation of placenta, and the one which is more common is Schultz method. Okay, this also can be asked as an MCQ. Which type of separation is more common? Skulls method or Duncan method? That time don't answer Duncan method. Okay, the answer will be Skulls method. That is more common. Okay, so now coming to the next MCQ. Okay, now you people are going to answer for this. Bleeding in the first trimester. Go through the question properly and you people are going to answer for me. Bleeding in first trimester with no uterine contractions or pain or no dilation in the cervix indicates option A, inevitable abortion, option B, threatened abortion, option C, missed abortion, option D, complete abortion. Yes, Vinita is telling option B, Sahi B, Aishwarya B, Divya Mohan B, Devi B, Vijay Lakshmi B. Any other answers? Threatened abortion? Yes. Whether your option is right? Whether your option is right? Yes. Everyone are super confident. Yes, you people are right. It is option B. It is called as threatened abortion. Okay, okay, let us quickly discuss about abortion. I know everyone will have little bit of confusion when you are studying abortion topic. Okay, let me clear it you. Okay, let me clear it for you people. Okay, with this single table I will clear all the types of abortion. Okay, so clearly listen to the types of abortion. First type coming to threatened abortion. See, threatened abortion. What do you see in threatened abortion? Here in threatened abortion, the process of abortion has started. Okay, but it is at a stage where it can be reversed. Okay, if you take some measures, if you could able to manage cheyagalite, you can stop that. Okay, you can prevent the baby getting aborted. Okay, you can prevent her from abortion. Okay, so here in threatened abortion, the abortion process has started, but it is at a stage where it can be reversed. That is threatened abortion. Now coming to inevitable abortion. What is inevitable abortion? So let me clear one topic at a single time and then we'll go to the other type of abortion. Okay, all right. Threatened abortion. What will be the complaints in threatened abortion? Yes, since it's an abortion, yes, there will be bleeding. So yes, there will be bleeding, right? So there is BPV, bleeding per vaginum. Okay, only little bit of bleeding will be there, which is called as spotting. Spotting means less bleed. Okay, very less bleed is called as spotting, vaginal spotting. You will see vaginal spotting here, and here the blood will be bright red in color. Remember, in threatened abortion, the bleed will be bright red in color, and okay, there will be very less bleed, which is called as vaginal spotting. And since here the process had not completely started, it can be reversed, right? Threatened abortion can be reversed. So that's why abdominal pain may or may not be there, plus or minus for pain in abdomen. Pain in abdomen may be there, can be there, or cannot be there. Okay, right. So drops like bleeding. Anusha is telling drops like bleeding. That is what we call it as spotting. Okay, danne spotting అని అంటాం, right? Okay, so abdominal pain may or may not be there. And coming to when you do physical examination in the client, when you see the cervical os is closed. Yes, since once your os get open, okay, once your os get opened, then nobody can, you and me cannot stop. It becomes complete abortion. Entire fetus will get expelled out, right? Here in threatened abortion, since it is, that is why we are calling it as reversed. Okay, here the os is closed, so that's why fetus is still inside. Okay, so that we can reverse the abortion. And here the uterus and period of uterus, the height of the uterus will correspond to the height correspond to that of period of gestation. So mother ఎన్ని వీక్స్ ప్రెగ్నెంటో అన్ని వీక్స్ కి యూటరస్ కూడా కరెస్పాండ్ అవుతుంది. ఫర్ ఎగ్జాంపుల్, ఇఫ్ యూ టేక్ మదర్ ఈస్ 22 weeks pregnant or 24 weeks pregnant, it will also correspond to that of that height. Okay, uterus also will correspond to that height of period of gestation. Okay, and when you do scanning in this client, there is, you can see fetal heart rate. Okay, cardiac activity is present. Okay, since that's why we are calling it as reversed. Okay, next, completed with threatened abortion. In threatened abortion, how you are going to manage this case? Just tell me, what is the management of threatened abortion? Yes, as you people said, it is not bed rest, it is rest. It is rest. You will give rest, that is conservative management you are going to give in this kind. You are going to give conservative management. You will ask her, okay, to avoid physical exercises, to avoid any strenuous activities in the home, and no sexual activity. Okay, and you will ask her to take rest, proper rest at home. It is not complete bed rest. You will ask her to take rest at home. This is conservative management, and no drugs are required in this case. Okay. Now coming to the inevitable abortion. Inevitable abortion, here it is exactly opposite to threatened abortion. Threatened abortion is at a stage where it can be reversed, I said you right. But here in inevitable abortion, here the abortion process had started where it cannot be reversed. You and me cannot do anything here. The fetus has to come out. Okay, that is inevitable abortion. Abortion is at a stage where it cannot be reversed. Okay, the fetus has to expel out. Okay, yes, obviously there will be bleeding per vaginum and there will be severe pain in abdomen. Okay, colicky pain, there will be severe pain in abdomen since the fetus is coming out, started coming out. Yes, there will be colicky pain. And yes, obviously os will be open here, and product of, when you do pervaginal examination, you can see os is open, and you can also feel that products of conception, since the process had started here, right? So now the fetal products started coming out. You can feel that when you do pervaginal examination, you can feel that. And uterus will correspond to that of period of gestation. Just now the process had started, right? Just now the process had started, and just now the fetus is coming out. Okay, still the fetus is inside, but yes, it started coming out. So that's why uterus will correspond to that of period of gestation. And when you do scanning, cardiac activity may or may not be there. Okay. Next, coming to incomplete abortion. Completed inevitable abortion, coming to incomplete abortion. The name itself says it is incomplete abortion. The name itself says it is incomplete abortion. In the sense, few fetal parts, here the abortion had started and the fetal parts is also started expelling out. Here in incomplete abortion, few fetal parts are retained inside. Okay. Few fetal parts are retained inside and few fetal parts are expelled out. That is incomplete abortion. Very easy, self-explanatory, right? And BPV, there will be severe bleeding. Okay, since the fetal parts are coming out, yes, there will be severe bleeding and pain in abdomen here. And when you do when you see, yes, obviously no need to do pervaginal examination also. Fetal parts are coming out, right? So os will be open, os is open, products of conception are coming out here. You can see that the products of conception, that is fetal parts, are coming out. Okay, and uterus will be less than, uterus height will be less than that of period of gestation. Why? Half of the fetus got expelled out, so that's why the height of the uterus would have decreased. So uterus height will be less than that of period of gestation here in case of incomplete abortion. Okay, and now coming to the when you do scanning in this woman, yes, obviously the fetus expired, right? Cardiac activity will be absent, and you can see products are partly retained. Okay, few fetal parts will be visible on ultrasound. Okay, right. Coming to the complete abortion. Next type of abortion is complete abortion. complete abortion. Here see, complete abortion, the name itself is telling you entire uterus is empty now, okay, and the uterus is empty now, all the fetal products or products of conception has expelled out, okay, fetal products expelled out here completely. So yes, obviously initially when the fetal parts are coming out, there will be bleeding per vaginum, and obviously once the fetus gets expelled out, bleeding will get stopped, right? Initially there will be bleeding, and then bleeding obviously it will stop. And then when you see when you do pervaginal examination, os is closed, yes, everything got completed here, fetus came out, fetus got expelled, and once the fetus is expelled, again os will get closed, right? So os is closed, os will be closed, and uterus will be obviously less than period of gestation, uterus is empty. And when you do scanning, I said you right, uterine cavity will be empty, bilkul nothing you can find in uterus, cardiac activity will be absent, there is no fetus, then where you are going to see cardiac activity? No cardiac activity, right? Next, coming to missed abortion. Missed abortion, yes, what is missed abortion? See, listen to this carefully. Here the patient is unaware of the death of the fetus inside the uterus. Here the fetus has expired inside the uterus and the mother is unaware of that, okay, that is missed abortion. And how does the mother comes to you? Okay, she will come to clinic saying that there is dirty brown discharge, very very important, dirty brown discharge, then you should think of missed abortion. And when you do pervaginal examination in her, os is closed, os will be closed, yes, still the died fetus is inside the uterus, right? So yes, obviously os is closed here, and uterus will be lesser than that of the period of gestation. Why uterus will be less than that of the period of gestation? ఎందుకుంటుంది చెప్పండి? ఎస్, ఫీటస్ షింక్ అయిపోయి ఉంటుంది లోపల, దట్స్ వై యూట్రస్ విల్ బి లెస్ దెన్ పీరియడ్ ఆఫ్ జెస్టేషన్, అండ్ ఈవెన్ యూపీటీ, యూరిన్ ప్రెగ్నెన్సీ టెస్ట్ విల్ బికమ్ నెగటివ్, ఓకే. And when you do scanning, you cannot see cardiac activity since the baby has died inside, yes, cardiac activity is absent, right? Now let me tell you the management. Threatened abortion, I have already told you the management of threatened abortion. Threatened abortion, here you are going to just ask the mother to take rest, okay, ask the pregnant woman to take rest at home. You will just give conservative management, you will ask her to avoid strenuous activity, no physical activity, no sexual activity, no drugs are required here in case of threatened abortion. Now coming to the inevitable abortion. Inevitable abortion, here the process, what is inevitable abortion? You and me cannot do anything, the process had started here. So how I am going to manage this case? Management will be, you will just do MTP, you will clear the case and you will send it to the home, okay, medical termination of pregnancy. Next, what about incomplete abortion? See, it is incomplete abortion, few fetal parts are retained inside the uterus, okay. Here you will just do suction evacuation, and clear the uterus, okay, clean the uterus, remove all the fetal products. Next, complete abortion. See, if any complete abortion, nothing is there, uterus is empty, here in complete abortion, what you are going to do? You will just give a TT injection, and if the mother is RH negative, you are going to give anti-D, and you will send her to the home. And then in missed abortion, you will do, yes, since you have to remove that died fetus outright, so that you are going to do MTP for that to clear the uterus, okay. Now, so these are the types of abortion. I think now you are clear about the abortions. If you are not making the notes, at least try to take screenshot now. Take the screenshot and save it in your gallery. See this slide frequently, okay, so that you can remember this for your tomorrow's ESIC exam. Abortion is very 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 important topic, okay, right. Moni, no need to give, in threatened abortion, no need to give complete bed rest. Just, I told you, right? That's just giving conservative management will be enough in threatened abortion. Okay. Right. So these are the types of abortion. Here, yes, you people have answered it right. Bleeding in first trimester with no uterine contraction or pain, no dilatation of cervix. Yes. Okay, let me ask you, you people a question here. Here they are saying you bleeding in first trimester, right? So what are the other conditions that you will think of when any pregnant woman comes to you saying that bleeding in first trimester? One is just now I told you abortion. What are all the other conditions that you will think of when any pregnant woman comes to you saying bleeding in first trimester? Just tell me. Let me see how many members are going to answer. Be quick. Placenta previa. Don't answer placenta previa. So, what is placenta previa? Tell me what is placenta previa? What is first trimester and when do you... Is there any... So, how you people are answering placenta previa for this? What is placenta previa? Placenta previa అనేది ఎప్పుడు స్టార్ట్ అవుతుంది? డ్యూరేషన్ ఏది ప్లసెంటా ప్రివియాకి? No, I am not asking you what do you mean by placenta previa. I am asking what is antepartum hemorrhage? Placenta previa, abruptio placenta comes in antepartum hemorrhage, right? After 28 weeks, yes. Kiran, yes, you people are right. First trimester is not 28 weeks, right? Yes, it is third trimester bleeding. Yes. Before the antepartum ante enti? Partum is labor. Antepartum, just before the labor. If you see bleeding, okay, just then you will think of placenta previa or abruptio placenta. But here it is. I am telling you first trimester bleeding. Okay. Yes. First trimester bleeding. Okay, అందుకే నేను that is why I am telling you whenever you are studying MCQ, study along with concepts. Do not by heart MCQs. It will not help you in any ways. It will not help you in any ways. Just taking any MCQ book from the market and just by hearting it will you can never clear the exam. I am telling you. Okay, just at least if you are studying 10 MCQs, study along with the concepts. Same MCQ will not repeat. It will not get repeated in your tomorrow's exam. But from that concept, if you are studying from that concept, you can see MCQs, right? So keep your concepts clear. Keep your concepts clear. Yes, excellent. Somebody have started. Okay, let me tell you for you people. If anybody comes to you, like if any pregnant woman comes to you with complaints of bleeding, in first trimester, have you people heard about a word called implantation bleeding? Implantation bleeding. So when after this formation of zygote and everything, that blastocyst will go and implant in the uterus, right, in the endometrium, which we call it as implantation. And during that time, the woman can experience bleeding, which is called as implantation bleeding, which is also called as Hartmann sign. Very, very important. I am giving you a Q mark for this. It can be asked as an MCQ in your exam. Hartmann sign or placental sign. Okay, which is nothing but your implantation bleeding. This can be there. The implantation bleeding there, that is in within 12 weeks, right? That's first trimester, right? Yes, implantation bleeding. This is bilkul normal. Implantation bleeding is bilkul normal. No need to worry here. Okay, few women will experience this. This is normal, which is also called as Hartmann sign. Okay, but now coming to abnormal. If any pregnant woman comes to you in the first trimester saying that bleeding, you will think of, just now I told you abortion. Okay, One case is abortion. Okay, abortion. Keep it aside. Now, what are all the other conditions? Yes, as you people said, excellent Loki. Yes, it might be molar pregnancy or it might be ectopic pregnancy. So, along with bleeding, how to differentiate all these things? Abortion, molar pregnancy, ectopic pregnancy, how to differentiate? So, in all these three conditions, the common symptom will be bleeding. Apart from that, any other symptoms will you see? Yes, that will help you to diagnose the other specific symptoms will help you to diagnose these cases. Okay, in abortion, yes, obviously the mother will tell you pain in abdomen, bleeding, and fetal products are coming out. Then you will think of abortion. Whereas in case of molar pregnancy, the mother will tell you, along with bleeding, mother will tell you grape-like vesicles are coming out. Grape-like vesicles are coming out. Then you will think of molar pregnancy. In ectopic pregnancy, there is a triad of symptoms, right? Can you people tell me what are the triad of symptoms in ectopic pregnancy? There is triad. Fastly tell me the triad, ectopic pregnancy triad symptoms. Yes, in molar pregnancy, HCG levels will be high and obviously alpha subunit, beta subunit, yes, thyrotoxicosis and hyperemesis gravidarum, all these things will be there. But apart from that, the specific symptom that you should remember is mother will be saying that pregnant woman will be saying you ki doctor or nursing officer, I am passing this woman is passing grape like vesicles. So then you will think of molar pregnancy. Okay. Okay. Yes, what you people are, yes, excellent, all of you people are right. Amenorrhea, yes, there will be amenorrhea 6 to 10 weeks of amenorrhea, and there will be pain in abdomen and bleeding per vaginum. So all these are the triad symptoms. If these triad symptoms if you could able to see, then you can think of ectopic pregnancy, right? And along with this triad, in the question they would also have mentioned UPT positive, and when you do scanning, on scanning we could able to see pseudo gestational sac, or the uterus is empty. So if these things, if you are finding in any question, then you can think of ectopic pregnancy. Okay, then you should think of ectopic pregnancy. Okay, right. Now coming to the next MCQ. So now tell me what is the answer for this. Before answering me, go through the question properly, read the MCQ twice, thrice, and then answer. Okay, don't be in that hurry to answer MCQs in tomorrow's exam. Okay, so don't do that. Study your MCQs twice and thrice and then answer. Folic acid supplements in pregnancy are mainly used for prevention of A. neural tube defects, B. gestational diabetes, C. anemia in pregnancy, D. anemia in fetus. Yes, you people are right. Excellent. Every one of you are right. It is option A, neural tube defects. So now folic acid, how to give folic acid? Can you people tell me how to give folic acid in pregnancy? Suppose let me tell you. Okay, I am giving you a case. You are going to tell me how much dose of folic acid you are going to give in that case. Now there is a diabetic female who had become pregnant and she is coming to you for her first visit. Okay, she recently got diagnosed with her pregnancy, and how much folic acid supplementation you are going to give in that case? Yes, tell me. So listen to my question properly. Yeah, I'll be telling you that also, Monica, don't worry. Yes, 1 month before conception you will be starting, that is the prophylactic dose. Okay, forget about that. I'll be telling you just now. I'll be telling you. I have given you a case. Listen to the case properly. There is a diabetic female who has become pregnant and she came to you, okay, got diagnosed with her pregnancy. How much folic acid you will ask her to take? Excellent, Vinita, Ravori, yes, you people have answered it as right, 4 mg. I am talking about high risk women, right? Diabetic female, she's said to be as high risk. Okay, so folic acid supplementations in pregnancy depends upon the risk group, whether the pregnant woman belongs to low risk group or high risk group. Okay, high risk is nothing but, just now I told you, diabetic females and those who have history of previous birth, previous babies with NTDs, that is anencephaly, spina bifida, whatever it may be, previous pregnancies of NTDs, all these are high risk. Okay, high risk and low risk. In high risk, you are going to give what folic acid. The dosage is 4 milligrams, 4 mg per day you are going to give. Okay, this is called as therapeutic dose. This is called as therapeutic dose. When you give 4 milligrams in high risk women, that is called as therapeutic dose. And now coming to the low risk women. See, coming to the low risk women, here the folic acid, no need to give 4 milligrams here. Here the recommendation says to give 400 micrograms per day. Okay, so this is called as, this is to prevent, right? In low risk women, here you are going to give this folic acid for the prevention of NTDs. So that's why the dose is 400 micrograms. Here you are going to, like you are going to treat, like you are going to give therapeutic dose here. Here it is prophylactic dose, prevention. Okay, prophylactic dose. Okay, right. Excellent. High risk, low risk. So this is how we are going to give folic acid in pregnancy. And this prophylactic dose, yes, you people, somebody have rightly said, this prophylactic dose, this folic acid supplementation, you will start 1 month, you need to give 1 month before conception. You need to start this one 1 month before conception till the end of first trimester. So entire first trimester she has to take this folic acid supplementation. But yes, practically this is not possible. Theoretically this has been mentioned in book, but yes, before even woman becoming pregnant, she will not come to obstetrician and ask for folic acid supplementation, right? So this is completely a theoretical point. This is not a practical point. Practically, once immediately she gets diagnosed with her pregnancy, once her UPT is positive, scan is telling that she is pregnant, yes, you can immediately start with folic acid supplementation. Depending upon the risk group, you will start with 400 or 4 milligrams. That depend upon the risk group. Okay, right. Now, any other doubts? Okay, now we are going to go for one-liners. Since I told you these one-liners are very important, these one-liners are from NTDs, neural tube defects. Now you people should answer for this. Okay, answer for first question. Most common fetal anomaly with face presentation. Okay, excellent Ramaswamy, excellent Priya. Yes, you people are right. It is anencephaly, the most common fetal anomaly with face presentation. Since what is the normal presentation? Vertex presentation, right? But whereas when you take anencephaly babies will not have this vertex part. They will not have this cranial vault. cranial vault is absent, cerebral hemispheres are absent in, the brain is directly exposed to out. Okay, so immediately once they born, immediately the baby dies. Okay, so since there is no cranial vault at all, face will come out. Okay, so that's why face presentation is seen in case of anencephaly. Okay, yes, you people rightly said the most common fetal anomaly with face presentation is anencephaly. Okay, now what is the most common malpresentation seen in anencephaly? Yes, yes, Vinita, yes, Navyasri, Pavitra, Arusha, yes, just now I told you face presentation. Either face has to come out, no cranial vault, now either face has to come out or buttocks has to come out, right? First malpresentation that you are going to see in anencephaly babies will be face presentation. The second one will be breech presentation. Okay, right. Now, investigation of choice for NTDs. What is the investigation of choice? What is the investigation of choice for NTDs? Just a minute. Alpha fetoprotein. Okay, most of you people are saying what I'm asking you, the investigation of choice for neural tube defects. Yes, Ravuri Vanilla have answered it rightly. Sangeeta, Navyasri, yes, you people are right. It is ultrasound. Ultrasound is the investigation of choice for NTDs. Okay. Next, most specific marker for the diagnosis of anencephaly. Most specific marker for diagnosis of anencephaly. Tell me, what is the most specific marker? Yes, you people are right. Priyadarshini, Navyasri, yes, you people are right. And what is the most common investigation that is done to rule out anencephaly? What is the most common done investigation? Most specific, as you people are answering, yes, it is acetylcholinesterase. What is the most common investigation that is done to rule out anencephaly? Just a minute, sorry guys. Most specific marker for the diagnosis of anencephaly, as you people said, it is acetylcholinesterase. Acetylcholinesterase and TIFA scan. No, the most common investigation done to rule out anencephaly. Most common, yes, maternal serum alpha fetoprotein levels. TIFA scanning or ultrasound is one and the same, right? Here I have already told you, right? Ultrasound. Investigation of choice is, yes, TIFA scanning. Ultrasound, TIFA scan, everything is done with ultrasound only, right? So most common investigation that is done to rule out is anencephaly is maternal serum alpha fetoprotein levels, which are raised here in case of anencephaly, right? Okay. Next, coming to best way to prevent anencephaly. What is the best way to prevent anencephaly? Already told you, just now I told you, right? Folic acid supplementation. Folic acid supplementation. I've already told you, right? How to give in high risk group, low risk group, what is the dosage, yes, and dose of folic acid per day to prevent anencephaly in case of low risk women, it is I've already told you, right? What is low risk in low risk women? What is the dose of folic acid? Folic acid dosage in low risk women. Excellent, Vinita. Vinita is quickly answering yes. Nice, nice, Vinita. Yes, 400 micrograms. And now dose of folic acid per day to prevent anencephaly in high risk women. In high risk women. Yes, you people are right, Sangeeta, Durga Devi. Yes, you people are right. In high risk women. Excellent, Durga Devi. It is 4 milligrams in case of high risk women. Now tell me, during pregnancy, the management of anencephaly. How do you manage? Now, as you people said, TIFA scanning. Okay, now TIFA scanning has been done by the radiologist, and radiologists have given impression that the baby has anencephaly. Now, what will be the management? What will be the management? No. I'm asking. See, folic acid is always prevention. Now yes, MTP. Excellent. Immediate termination of pregnancy need to be done, irrespective of, there is no upper limit at all. Okay, for severe, as per the latest MTP, you people, I think you people are familiar with this. MTP amendment 2022, MTP amendment 2022 says for severe congenital anomalies there is no upper limit if medical board permits. Okay, if medical board permits, there is no upper limit. Okay, whenever the woman gets diagnosed with this fetus has anencephaly, immediately you can terminate. There is no upper limit at all. There is nothing called 20, 24. Irrespective of period of gestation, you can terminate the pregnancy if there is severe congenital anomalies like anencephaly. Okay. Anyway, anencephaly babies, just now I told you, right? Immediately once they born, after birth, immediately they will the baby will die. Okay. So that's why it's best to terminate the pregnancy. So MTP 2022, there is no upper limit. No upper limit for severe congenital anomalies. Okay, right. So Madhavi, MTP revise ayindi. Okay, revise ayindi. MTP amendment in 2022 lo bill pass chesaru. A bill lo ivaithe mention ayi unnai. That is what now we are following. Okay. Now let me tell you about MTP amendment 2022. Okay, MTP amendment lo changes ఏ వచ్చినాయంటే now the abortion is done till, previously it was 20 weeks, now it is 24 weeks. Okay, but in case of contraception failure, even now the upper limit is 20 weeks. Okay, and just now I told you, right, for severe congenital anomalies, there is no upper limit. 20 weeks, 24 weeks, 30 weeks, whatever it may be, whenever it is getting diagnosed, yes, you are going to terminate the pregnancy. There is no upper limit. Okay, if medical board permits. If your medical board permits. Okay, right. Now, so these are the things that you need to remember. Let me erase it. I think you people have copied this. Okay, now what is this? Okay, now started answering. Vinita, yes, started answering this question. Okay, which of the below is a confirmed indication of pregnancy? Here they are asking you the diagnostic sign of pregnancy. Confirmed indication. Okay, here they are saying they're asking you 100% which option is suitable for the confirmation of pregnancy. Option A, fetal heart rate in ultrasonogram, nausea and vomiting, beta HCG in urine. Option D, amenorrhea. Yes, what is the option, right option? Yes, every one of you are right, 100%. Yes, ultrasound. Usually we diagnose pregnancy by seeing ultrasound only, right? So fetal heart rate, when you, fetal heart cardiac activity when you see on ultrasound, yes, that will 100% gives you confirmation that the woman is pregnant. Okay. Yes, Sai Teja, you are right. It is fetal heart in ultrasound. Next. Now tell me the for this. Now answer for this. Neglis rule. Okay, here they are asking you the Neglis rule is used to calculate. Option A, cervical dilatation. Option B, amniotic fluid. Option C, expected date of delivery. Option D, none of the above. Every one of you are right. This is a very lollipop question. Yes, it is expected date of delivery, EDD. Okay, right. So what is Neglis rule? Can you people tell me what is, quickly tell me what is Neglis rule? Yes, here you, for the last menstrual period, you are going to add 9 months plus 7 days, right? 9 months plus 7 days, then you will get expected date of delivery. This is Neglis rule, right? Excellent. 9 months plus 7 days. You are going to add, then you are going to get expected date of delivery. Yes, Neglis rule is obviously used to calculate expected date of delivery. Next, coming to the next question. Now you people should answer. Let me see how many members is going to answer for this question. Even this question I think they have asked in NORCET 2021. When I am writing, I think I got this question in my exam. The normal order of events taking place during the second stage of labor is. So they are asking you about the events that are taking place in second stage of labor. That is, they are asking you the mechanism of labor. Now tell me, option A, which, go through the options clearly and then answer. 9 months, still you are in Neglis rule. Gayatri, come to the next question. Okay, we are going with our next question. Okay, mechanism of labor. Can you people tell me? Yes, why C, Prasad? Any confusion? There should be descent, then flexion, then internal rotation, right? C is wrong. All the okay. So now don't ask me to explain mechanism of labor. It's such a big topic. I have already explained very detailedly. I have explained the mechanism of labor in my one of my video. It is available on my channel, Medsee Nursing YouTube channel. For free, it is available. Go check out the playlist. This is the video. I'm giving you the thumbnail of that video. This is how the thumbnail will be there. The part 3. In this part 3, you can find the mechanism of labor. I have explained you clearly there. Go check out the video and go through the mechanism of labor there. Okay. So your doubts will get cleared. Okay. So yes, as you people said, option C is correct. Descent, flexion, internal rotation, crowning and extension. Next, which of the below is true and with regards to pregnancy induced hypertension? Here they are asking you which of the below is true with regards to the pregnancy induced hypertension. Option A, there is raised BP before 20 weeks of gestation. It is also called as typing error. It is also called as gestational hypertension. Option C, visual disturbances are always present. proteinuria is usually present. They are asking you about PIH, pregnancy induced hypertension. Tell me, pregnancy induced hypertension. Okay, most of you, Vijay Lakshmi, Durga, Navyasri, B, gestational hypertension, excellent. Still few members are answering D. Loki D, Suha D, most, okay. So why there is doubt? No need to have doubt. Yes, it is PIH is also called as gestational hypertension. Why option A is wrong? Here they are saying BP is raised before 20 weeks of gestation. My dear guys, please remember, in PIH, if you want to call it as PIH, pregnancy induced hypertension, the BP has to rise after 20 weeks. Okay. Then in a normal pregnant woman, if she develops hypertension after 20 weeks of her gestation, then only you are going to call it as pregnancy induced hypertension. If BP is raised before 20 weeks, then you should not call it as gestational hypertension. Okay, it becomes chronic hypertension. I think you people will have little bit of confusion with these terms. What is pregnancy induced hypertension? What is gestational hypertension? What is chronic hypertension? Pre-eclampsia, eclampsia, HELP syndrome? Let me tell you. All these are MCQs. Each and everything which I am going to say now is an MCQ for your tomorrow's exam. I want all of you to make notes along with me now. Okay, right? So I'll give you a case and let me explain along with a case I will explain you all these terms. Okay. Now, let's suppose there is an woman. I am giving you the case and you have to diagnose that. Now there is a case who is there is a pregnant woman who is non-hypertensive, bilkul normal, no hypertension at all, who is non-hypertensive. Okay, if she becomes hypertensive, okay, if she develops hypertension after 20 weeks, okay, then why after 20 weeks? Maybe due to some placental pathology. Placenta is responsible for PIH. Okay, always remember, placenta is responsible for PIH. Due to placental pathology, then you are going to call it as PIH. Okay, PIH is also called as gestational hypertension. Okay, again I am telling you, if a pregnant woman who is non-hypertensive becomes hypertensive after 20 weeks due to placental pathology, what is the cutoff for hypertension? What should be the value for hypertension? If you want to say that this pregnant woman is hypertensive, what is the cutoff? Yes, let me see who is going to give me the quick answer for this. What is the cutoff? Yes, 140/90. Excellent. It is not 120/80. Loki, it is normal, right? 120/80 is normal. Then you will be calling it as normotensive. 140/90, 4 hours apart, right? 2 readings. So okay, cutoff you just remember 140/90. Okay. Okay, there is a non-pregnant. There is a pregnant woman who is non-hypertensive. She is coming to you after 20 weeks saying, okay, the rise in BP. Okay, once in that case you have checked BP and now the BP is 140/90. Okay, then you are going to immediately label it as PIH, pregnancy induced hypertension. Usually we don't write it as PIH. In diagnosis, we don't write it as pregnancy induced hypertension. We write it as gestational hypertension. Provisional diagnosis. Gestational hypertension is the provisional diagnosis that you will be writing. And in this, same, if the same PIH case, if the same woman, if she develops any signs of end organ damage or proteinuria, I'll tell you what are the signs of end organ damage just now. Just listen to this. If this PIH woman, if she develops any end organ damage or proteinuria, then immediately you are going to call her as, you will no more call it as gestational hypertension, you will now start calling her as pre-eclampsia patient. Okay, and there are two types of preeclampsia. I think you people are aware of that. Preeclampsia. So there are two types. It is mild preeclampsia and severe preeclampsia. Mild preeclampsia, if the BP is greater than 140/90 and it is less than 160/110, then you are going to call it as mild preeclampsia. When are you going to call it as severe preeclampsia? If the BP is greater than 160/110, then you are going to call it as severe preeclampsia. Can you people tell me what is the drug of choice to treat hypertension in pregnancy? What is the drug of choice to treat hypertension in pregnancy? Let's suppose now there is a pregnant woman where there is 170/120. Which drug you are going to give? Excellent. IV labetalol you are going to give. The drug of choice is labetalol. Labetalol will have both alpha and beta action. It will block both alpha and beta. Okay. It has mixed action. Right. Till now you are clear, right? Now if this preeclampsia patient, listen to this carefully, if this preeclampsia patient, once if she develops GTCS, what is GTCS? Generalized tonic-clonic seizures or coma, or if she goes into coma, then you are going to call it as, now you are not going to call it as preeclampsia, you start calling her as eclampsia patient. Eclampsia patient, right? Can you people tell me what is the drug of choice for eclampsia? What is the drug of choice to prevent eclampsia? I'm asking you the prevention. So now you know that the BP is very high in this woman. She may throw seizures at any time. So keeping that in your mind, you will start giving one drug. What is the drug? Yes, excellent. Durga Devi, Bindu Vagaturu, excellent Bindu, you are right, it is MgSO4, magnesium sulfate is a drug that is used to prevent eclampsia. Okay, even to treat eclampsia, magnesium sulfate is the drug of choice. Okay, next, coming to the costs. Okay, now one more interesting question. Yes, let us see how many members is going to answer for this. My dear future ESIC nursing officers, yes, answer this. The causative agent for bacterial vaginosis is option A, Candida albicans, option B, Chlamydia trachomatis, option C, herpes simplex, option D, Gardnerella vaginalis. B, D. Lot of confusion between B option and D option. Okay, I want only single option. Tomorrow in your exam only one option is allowed, right? And for the very first time UPSC is going to conduct your ESIC exam. I want all of you to be thorough with your revisions. I don't know how the question paper will be framed. Okay, for the very first time in history UPSC is going to conduct your ESIC exam, right? Be careful, study properly. Competition is going very high in all India level. Okay, don't be lazy, stick to your study plan. Need to wake up at 5 o'clock? Yes, wake up at 5 o'clock. Like I'm like night owl. I'm fond of studying in the night time. Okay, till 2 o'clock, 3 o'clock I study, and morning I wake up at 11 o'clock. So that's how I study. And a few people will be like early birds. Okay, they are early birds, they wake up at very soon they will wake up and they will study 3 o'clock, 4 o'clock. Yes, I want all of you to allot time, pakka time to be allotted for your studies. Okay, need to complete OBG within this time. You should complete your OBG within that specified time. Okay, very less time, that is 60 days I think you have now in your hand properly. Utilize this 60 days properly for your exam. Do not get demotivated. No one daily, don't expect someone to motivate you people. Okay, don't expect, never expect that. Have self motivation. Okay, have self motivation. Yes, 91 are attending live. Yes, let us see how many members are going to crack this exam tomorrow. Yes, chlamydia trachomatis. Okay, most of you have gone wrong with this option. Okay, let me tell you, the correct option for this is option D, Gardnerella vaginalis. Those who have answered it as D, I think I have prepared for 3 months. My preparation strategy is little bit different, Suha. Let me do a video on my preparation. I have studied for 12 hours. My study time was little bit complicated. Okay, so no need to study 12 hours. It's not needed. If you want a nice rank, yes, you need to go. But if you want to get selected, no need to study for 12 hours, 13 hours. My study plan was little bit different. I was studying for 13 hours, 14 hours. My study plan was different at that time. Yeah, that is what you have. Also, most of you people, those who are watching this video, would be attending your duties in the wards. You need to attend your duties. You need to take care of your family, and simultaneously at least study 4 to 5 hours per day. That's enough. You'll surely crack the exam. That's 100% assurance from my side. Okay, my dears, most of you have gone wrong with this option. The causative agent for bacterial vaginosis is Gardnerella vaginalis. I think you are studying less. You are spending less time with your gynecology. Let me tell you about bacterial vaginosis quickly. Most of every exam they are asking you about infections, about the candidal infection, about the bacterial vaginosis. From the gynae they are repeatedly asking you this question. Okay, let me quickly tell you what is this bacterial vaginosis. Okay, I want all of you to make notes along with me. Bacterial vaginosis. See, bacterial vaginosis, the causative agents are, as I have said, Gardnerella vaginalis. The other one more bacteria also causes bacterial vaginosis in females, that is Mcqs. But remember, at least remember Gardnerella for your exam. Okay, all right. Now, how does a woman comes to you? Okay, once if she is infected with this bacteria, how does the woman comes to you? With what complaint she will come? See, the symptoms will be, she'll come to you and say that she's having grey or white discharge from the vagina. Grey or whitish discharge, plus foul, and that discharge will have foul smelling. Okay, foul smelling grey white discharge. And bacterial vaginosis, there will be no itching. Yes, you people, yes, Arusha, you are right, there will be no itching. No, Pavan, there is no itching here in case of bacterial vaginosis. No itching. Okay, this is how the woman comes to you, saying that there is discharge which is foul smelling, no itching. And once if you add 10% KOH, that is potassium hydroxide, to the discharge, you will get foul, fishy odor. Okay, you will get that fishy odor. Okay, if in case of bacterial vaginosis, for the vaginal smear, if you add 10% KOH, that is potassium hydroxide, you will experience that fishy odor, which is called as whiff test positive. Whiff test positive. Very, very important. I am giving you Q marks. Please write it down. It will be asked in your exam. And same vaginal smear, if you send it to the microbiology lab, and once the microbiologists do gram negative staining and add saline drops on that smear and put it under microscope. In microscope, this is how the cells appear. Okay, if this is the epithelial cells, take this as epithelial cells. The skin cells. Okay, on top of it you can find bacteria, Gardnerella. You can find like this in the gram negative staining. This gram negative rods will appear like this. Same like this, you can similar to this you can see under the microscope, which are called as clue cells. Where do you will see this in saline microscopy after gram negative staining. Okay, anything else? If you want to see bacteria under microscope, you need to stain, right? So this is, since it is a gram negative coccobacilli, Gardnerella vaginalis is a gram negative coccobacilli, you will do gram negative staining. Okay, right. So leave that. And what will be the treatment here? What will be the treatment in bacterial vaginosis? Since it's a bacterial infection, you need to give antibiotics. It is metronidazole. Yes, completed. Now let me give you 3 cases. I'll give you 3 more cases you are going to answer. I'm erasing this. I'll give you 3 more case scenarios you are going to answer me. Okay, listen to this properly. Now there is a female who comes to the clinic saying that she has cheesy vaginal discharge. What do you think of? And there will be itching. So what do you think of? Cheesy vaginal discharge. And there is one more case who comes to you saying greenish yellow discharge. Greenish yellow vaginal discharge, which is foul smelling. And one more case, she is coming and telling you there is white or grey discharge plus foul smelling discharge, gray or white discharge. So what? Tell me about, now tell me this case. Cheesy white discharge. What do you think of? Excellent. Cheese. Anywhere cheese. Think of candida. Candidal vaginitis. Candidiasis. You will think of candidiasis. Next. Now, what about this case? The second one. I am asking you what. Now tell me about excellent. Second one is trichomoniasis. Trichomonas vaginitis. You will think of trichomonas vaginitis. And one more important point that you should remember about trichomonas vaginitis is, can you people tell me? One important feature you will see in trichomonas vaginitis infection. In physical examination, one important sign you will see. What is that? I am asking you about trichomonas vaginitis. Excellent, Geeta. Excellent, Priyadarshini. You are right. It is strawberry vagina. Okay, in trichomonas vaginitis, this is again one more important MCQ. Vagina appears, red spot appear on vagina, that cervix. Okay, and you can see that cervix appears to you as strawberry. Okay, which is called as strawberry vaginitis. which is also called as strawberry vagina. Okay, that reddish spot will appear in the vagina, which will appear as which will be similar to that of your strawberry. So that's why it is called as strawberry vagina, right? That is in case of trichomonas infection. Now, I've already told you this case, right? White greyish discharge with foul smelling. Yes, you will think of. Just now I told you what is that infection. Just now I told you that is, yes, Gardnerella. Any doubts? Yes. Yes, good evening, Pavani. Rella or Mobilincus. One more organism that you need to remember is Mobilincus. Okay. So these are the three cases that I have given you people. And yes, now coming to the other MCQ. Now tell me, what is this? What is the answer for this? Which of the below is not? They are asking you. Kindly go through the question. Okay. They are saying that which is not a component of HELLP syndrome. HELLP syndrome, which is not a component of HELLP syndrome. A. Hemolysis. B. Elevated liver enzymes. C. Bleeding per vagina. D. Low platelet count. Excellent, Bindu Vakaturu, Divya Mohan, Haimavati, Navyasri Devi. Every one of you are right. Option C is wrong. In the sense, it is not a component of HELLP syndrome. You people are right. Option C. Okay, bleeding per vagina is not seen in case of HELLP syndrome. What is HELLP syndrome? HELLP. See, HELLP syndrome is a complication of severe preeclampsia. HELLP syndrome is a severe complication of severe preeclampsia. Okay, and once the woman develops HELLP syndrome, in case of severe preeclampsia, immediately you need to terminate the pregnancy. Irrespective of period of gestation, if the pregnant woman develops HELLP syndrome, yes, quickly deliver. Okay. What is HELLP syndrome? Abbreviation is HEAD stands for hemolysis. HEAD stands for hemolysis. EL stands for elevated, please don't mind my handwriting, liver enzymes. Your SGOT, SGPT, everything is raised. LP, low platelet, that is thrombocytopenia. So these are seen in case of HELLP syndrome. Okay, H for hemolysis, EL for elevated liver enzymes, LP for low platelet count, that is thrombocytopenia. Next they are asking you what is cerclage is done for patients with. Cerclage is a procedure that is done for the patients with option A, incomplete abortion, option B, complete abortion, option C, threatened abortion, option D, incompetent cervix, that is cervical incompetence. Yes, Bindu Vakaturu is telling D, Vinita is telling D, Hemavati D, Navyasri D, okay, D. Yes, you people are right, it is correct. Incompetent cervix, cervical incompetence. So see here, what is how does the patient present in cervical incompetence is cervical incompetence. See, in cervical incompetence, the patient will, this in MCQ you can see this symptom, second trimester recurrent abortion, then immediately think of cervical incompetence. Okay, in cervical incompetence, the woman comes to you with second trimester recurrent abortion, and here in this case you will stitch the cervix. Since the cervix is losing its tone, you will stitch the cervix and send her back to the home. You can do vaginal cerclage, which is called as cerclage. Which is vaginal cerclage, and one more we have is abdominal cerclage. Abdominal cerclage, forget about it. Once you do abdominal cerclage, you are not going to deliver vaginally. LSCS is done, so keep it aside. Now coming to vaginal cerclage. Vaginal cerclage is of two types. Okay, by two methods you can do vaginal cerclage. One is McDonald's encerclage and Shirotka's encerclage. Shirodkar encerclage. The one which is most commonly done is McDonald's vaginal cerclage is most commonly done nowadays. And here in McDonald's and Shirodkar, you are going to stitch you are going to stitch the cervix. Remember, here you are stitching, making the stitches in the cervix, right? And how the woman will deliver. So at 37 weeks you are going to remove the stitches. You are going to remove the stitches at 37 weeks, otherwise it can lead to uterine rupture. Otherwise the uterus will get ruptured if you are not removing the stitches. Okay, right. So this is about the cerclage. Next, now answer this question. Complete dilation of cervix to the birth of a baby is staged as. Complete dilation of cervix to the birth of a baby is staged as. Option A, stage 3 of labor. Option B, stage 2 of labor. Option C, stage 1 of labor. Option D, stage 4 of labor. Which one is correct? Please don't answer, please don't give me a wrong option for this. This is a very neonate, even neonate can answer this. Yes, B. Yes, you people are right. Option stage 2 of labor. So let me quickly revise the stages of labor, stages of true labor. I want all of you to make notes on this. Stages of true labor. So stage 1. What is stage 1? Stage 1 starts with the onset of true labor pains, and it will end with the full dilatation of cervix. Full dilatation of cervix. Full dilatation of cervix means fully dilated cervix will be measuring about 10 centimeters. Okay, so 10 centimeters is a fully dilated cervix. So stage 1 starts with the onset of true labor pains, it is and ends with full dilatation of cervix. And please remember, cervical dilatation, let me write it down here. Cervical dilatation, what should be the minimal cervical dilatation in case of nulliparous and in case of multiparous? Can you people tell me? In nulliparous, who is answering 20 centimeters? What is cervical dilatation? What is the minimal cervical dilatation in case of nulliparous? Tell me. Excellent, Esther. It is 1.2 centimeter per hour. 1.2 centimeter per hour in case of nulliparous. In case of multiparous, it is what should be the minimal dilation per hour? 1.2 in case of nulliparous, and in multiparous women, no, it is not. Okay, sorry Durga, it is not 2 centimeters, it is 1.5 centimeters per hour. In case of nulliparous, it is 1.2 centimeters per hour. In case of multiparous, it is 1.5 centimeters per hour. But WHO says it is 1 centimeter per hour. Forget about nulliparous, multiparous. WHO says it should be at least 1 centimeter per hour. Previously, this was earlier. Now WHO is saying it can be also less than 1 centimeter per hour. Okay, it can be less than 1 centimeter per hour also, right? Forget about, at least remember this one. Okay, all right. Now this is a cervical dilatation that you need to remember. and you people know stage 1 has two phases, right? Latent phase and active phase. Please write it down in your registers, make notes along with me. Stages of labor. Labor is a must study topic. With surely you are going to get questions from labor. Okay, then tomorrow don't go there and regret. Okay, so make notes along with me. This is very important. Latent phase, I'm also giving you the updates. See, now tell me, latent phase is, what is latent phase and what is active phase? Previously, now new updates has come, right? Latent phase is still 4 centimeters and active phase is from 5 centimeters till 10 centimeters, right? Previously it was 3 and active phase was from 4. Now it was different. Everything changed. Latent phase is still 4 centimeters and active phase is from 5 centimeters as per the latest labor care guidelines. I've already told you, right? According to ACOG it is 5 centimeters, yes, but remember, according to WHO labor care guide, labor care guide, yes, kindly remember, because you people will confuse easily. Surely you are going to get questions from WHO labor care guide. What does WHO labor care guide says to you? WHO labor care guide, that is your next generation partogram. Active phase, latent phase is still 4 centimeters and active phase is from 5 centimeters, begins from 5 centimeters, right? Okay, so this you need to remember. This is very, very important. I am giving you Q marks. Next, stage 2. Coming to the stage 2. Stage 2 of labor. In stage 2 of labor, when does it start? Stage 2 starts from full dilatation of cervix till full dilatation of cervix till expulsion of fetus, till the expulsion of fetus. And what is the average duration of, now listen to the question properly and answer. What is the average duration of second stage of labor in case of nulliparous and in case of multiparous? Now you people should answer, right? Average duration of second stage of labor. Again, this is a Q mark for your exam. Average duration of second stage of labor in case of nulliparous women and in case of multiparous women. 30 minutes in multi. I'm not asking you maximum, I'm asking you average duration. That is why I'm telling you, listen to the question and then answer. I'm not asking you maximum duration, I'm asking you average duration of second stage of labor in case of nulliparous. What if your tomorrow's ESIC MCQ is same? Average duration of second stage of labor in case of nulliparous. What you'll answer? 2 hours is wrong. That is not the average duration. See, nulliparous, it is 1 hour. That is the average duration is 1 hour. Best if you can select option 50 minutes. If you select 50 minutes, that will be best. Okay, if 50 minutes is not in your option, then go with 1 hour. Multiparous, it is 30 minutes. This is the average duration of second stage of labor in case of nulliparous, multiparous, right? No confusions. And coming to the next stage, stage 3. Now coming to the stage 3. Stage 3 starts after expulsion of fetus till delivery or till the expulsion of, and it will end when the stage 3 gets ended. by the expulsion of placenta. Third stage of labor is starts from after expulsion of fetus and till the expulsion of placenta and membranes. Okay, and what is the duration here? Here the duration will be it should be less than 30 minutes. Okay, in every woman, okay, third stage of labor should be less than 30 minutes. But if you usually we follow something called AMTSL, active management of third stage of labor, right? In third stage, I think you people are remembering this, very important, active management of third stage of labor, right? And by following this active management of third stage of labor, you will decrease this 30 minutes to 5 minutes. Okay, you will decrease this 30 minutes to 5 minutes with this active management of third stage of labor. And now you people are going to answer me. Now you are going to answer me, what is active management of third stage of labor? Tell me, what is the active management of third stage of labor? No, I'm asking you what are the steps in active management of third stage of labor. It's very important. Active management of third stage of labor. Write it down, please. First step, injection. As soon as the baby is born, you will immediately administer injection oxytocin. As per the WHO recommendation, injection oxytocin 10 international unit IV infusion. By IV infusion or intramuscularly, you are going to give this injection uterotonic. Next one is DCC, delayed cord clamping, for at least 60 seconds you will wait and then you are going to clamp so that it will prevent the fetal anemia and later stages. And next, third step is delivery of the placenta by CCT, controlled cord traction. And the last step is uterine tone assessment, intermittent assessment of uterine tone. These are the 4 golden steps that you need to remember. By following these steps, you are going to decrease the third stage of labor from 30 minutes to 5 minutes. Understood? Right. Now coming to the next MCQ. Now you people should answer me this question. Progressive thinning and shortening of cervix is defined as. Tell me. Progressive thinning and shortening of cervix is defined as. It's a very basic question again. I think all of you can answer this. Yes. Previously, fourth step in active management of third stage of labor. Previously, step 4 was uterine massage, but now they have removed, as per the in latest guidelines they have removed, and they have kept another point, intermittent tone assessment, uterine tone assessment. Yes. Okay, now tell me about progressive thinning and shortening of cervix is defined as. Option A, most of you are right. This is a very basic question. Progressive thinning or shortening of cervix is called as cervical effacement. Okay, right. Now answer this question. Positive definitive sign of pregnancy. Here they are asking you positive definitive sign of pregnancy. Option A, amenorrhea. Option B, quickening. Option C, visualization of fetus by ultrasound. Option D, uterine enlargement. Option D, uterine enlargement. So Monisha is telling option A, Navyashri C. Here they are asking you definitive sign. That means diagnostic sign they are asking you. They are not asking you probable sign, presumptive sign. They are asking you diagnostic sign. What is a diagnostic sign? Visualization of fetus by ultrasound. Excellent. Those who are answering this, yes, you people are right. It is visualization of fetus by ultrasound. Okay. Option A, amenorrhea, is not the right one. Option B, quickening. What is quickening? What is quickening? What is quickening? What do you mean by quickening? Perception of first fetal movements by mother is called as quickening. In case of primary, in case of multi, primary gravida and multi gravida. In primary gravida, quickening is seen at 18 to 20 weeks. Multi gravida, it will be little bit earlier, 16 to 18 weeks. So quickening in case of primary, it is 18 to 20 weeks. In case of multi, it is 16 to 18 weeks. Again, this is an MCQ for your exam. Again, I am giving you a Q mark for this one. Yes, the third one is correct. Visualization of fetus by ultrasound. Now tell me, what are all the diagnostic signs of pregnancy? Let me tell you, I think you people have confusion. Let me clear it for you people. What are all the diagnostic signs of pregnancy? Diagnostic sign means 100% that will tell you that the woman is pregnant. Don't tell me amenorrhea, all these things. This is not diagnostic sign. Amenorrhea is not a diagnostic sign for pregnancy. Amenorrhea can be due to many things. Yes, diagnostic signs of pregnancy. Yes, as you people said, it is ultrasound. Seeing the fetus on ultrasound confirms you 100%, and seeing the cardiac activity, listening to the fetal heart sounds. Fetal heart sounds, please remember, on Doppler, it can be heard at 10 weeks. By stethoscope, by your stethoscope, you can hear it from 18 to 20 weeks, right? And the other one is fetal heart, when you can palpate the fetal parts. Okay, when you do parabdominally, when you palpate the fetal parts, that also confirms you that the woman is pregnant, right? So fetal parts palpable. So when does the fetal parts become palpable? Tell me, what time? At 20 weeks of gestation, from 20 weeks of gestation, fetal parts become palpable. Okay, and the last one is X-ray. You can also do an X-ray and see the fetal bones, right? Usually you don't do X-rays in pregnancy. Okay, right. So these are the things that you should remember for your exam. Now coming to the next MCQ. Tell me, what is here they are asking you false labor manifestation are as follows except. Option A, contraction less than with activity or less. Here they are asking you about false labor. Okay, don't confuse. Here they are asking you about false labor. They are asking you except, that means you need to select the wrong option here. Option A, contraction lessen with activity or rest. Option B, cervix progressively effaced and dilated. Option C, abdominal discomfort. Option D, contractions or irregular. I think you people are aware of what is true labor pains, what is false labor pains, right? C. Yes, you people are right. Don't answer C, my dear Pawan. Okay, those who are answering it as option B, you people are right. Option B is right. You will never see cervix getting dilated and effaced in case of false labor. Then it becomes true labor. Once if your cervix shows dilatation and effacement, then it becomes true labor. Here they are asking you about the false labor, which is wrong. Yes, this is wrong, right? Option 2 is wrong, where this option 2 you will see in case of true labor. Okay, right. Okay, let me tell you quickly about true labor and false labor. Should I explain true labor and false labor, or shall I go with other MCQ? Yes, B, you are right. Nagamani, you are right. Excellent. Those have answered option B, it's 100% right. Cervix dilatation and effacement you will never see in false labor. Should I explain about, okay, so Pavan is telling me to explain. Okay, everyone is asking me to explain. Okay, let me quickly explain you about, okay, let me take a new slide here. Okay, right. So along with me, please make the notes. True labor and false labor. True labor and false labor. What is true labor? See, true labor, the pain will be regular and rhythmic. Something it will show on-off phenomena. Okay. Yes, it will show some. Yes, you are right, Lakshmi, Alam, you are right. It is regular and it is rhythmic. That means it will show on-off phenomena. For some time pain will be there and again gayab, again you will pain get started. So that is on-off phenomena is seen in case of true labor, right? Whereas here in false labor it is irregular, the pain will be irregular and constant. Here the pain will not show on-off phenomena, here the pain will be constant, right? And pain is located in location of pain in true labor, pain is located in the lower abdomen, which will radiate. It is radiation pain. In case of true labor it is radiation pain, whereas false labor it is not radiation pain. Here it will radiate to thigh, back. Okay, the mother will be experiencing pain over that radiating pain in the thighs and back. Okay, whereas here in false labor there is no radiating pain. There is no radiating pain. Only there will be pain in the lower abdomen. Lower abdomen pain. Okay, and next here show cervical dilatation plus effacement is seen here in case of seen, whereas cervical dilatation and effacement is absent here. And you will also see show is bloody mucoid discharge. Blood with mucus is called as show. You can show is present in case of true labor, whereas in case of false labor show is absent. And if you provide rest and if you give enema to the mother, or if you give sedatives, in false labor pain gets subsided, pain is relieved, whereas here in case of true labor it will never subside. It is true labor, right? Cervix is also dilating. The only thing is it should get delivered, right? It will never subside in case of true labor. So now see the question, now see the option here. False labor manifestations are as follows, except cervical effacement and dilatation I told you in true labor, right? You will see this in case of true labor, and remaining everything, contractions, yes, with when you ask mother to lessen the activity and when you give rest, yes, obviously the pain will go down. Abdominal discomfort will be there in both the cases, true labor and false labor. Contractions are irregular in case of false labor. Yes, all this I have told you right here. Okay. Alright, now coming to the next MCQ. Now tell me, para is defined as, what do you mean by para? Para is defined as option A, total number of, yes, total number of pregnancies. Option B, number of past pregnancies gone beyond period of viability. Option C, born from beginning of 32 to 42 weeks. And D, any pregnancy that gets terminated before period of viability. Which one is correct? Yes. Which one is correct? Option B, option B. That means, yes, what do you mean by para? Number of past pregnancies gone beyond the period of viability, that is 20 weeks, is called as parity. Okay. What is gravida? Let me quickly tell you what is gravida and what is parity. I want all of you to write notes along with me. Gravida is nothing but present pregnancy plus number of times that female has conceived. Okay, present pregnancy plus number of times that she has become pregnant comes in gravida. Okay, in gravida you are also going to take present pregnancy. Okay, whereas in parity is number of pregnancies that has crossed 20 weeks is called as parity. Okay, here in parity present pregnancy is not included. Present pregnancy, you should not take the present pregnancy in case of parity. Only present pregnancy you will take in case of gravida. Okay, no confusions, gravida, parity, right? Okay. Next, quickly tell me about this eclampsia. One more MCQ. We will end the session within a while. So answer this MCQ. Eclampsia includes by the following except option A, seizures, option B, marked proteinuria, option C, mild facial edema. Here they are asking you about eclampsia, which symptom is not usually seen in case of eclampsia. Option A, seizures, option B, marked proteinuria, option C, mild facial edema, option D, BP greater than 160 by 110 mm of Hg. Yes, quickly answer this and kindly prepare the notes. Notes will serve you as shield in the war. I have already told you in my previous video. Those who have not watched my previous video, study plan video, go watch the study plan video in my channel. And those who are watching this live session, do like this video so that it will get suggested to those who are, to the others who are preparing for ESIC exam. In that way you will become helpful for that people. Okay, yes, and those who have not subscribed to my channel, do subscribe and support Medsee Nursing YouTube channel for interesting live classes like this. Okay, option, okay, eclampsia does not include, yes, those who have answered it as option C, you people are right. I've already told you, right? Yes, eclampsia, if a PIH case develops, for example, if there is a pre-eclampsia case, if she develops seizures, pre-eclampsia is nothing but hypertension with end organ damage. I think I have forgotten to say signs of end organ damage. Let me tell you now. Here I think in pre-eclampsia, when I was discussing pre-eclampsia, I think I have not mentioned about signs of here end organ damage. Let me tell you what are the signs of end organ damage. Quickly go there and write it down somewhere. Okay, just beside to this MCQ. Signs of end organ damage. Signs of end organ damage. Very, very important. The first one is serum creat. Serum creatinine going greater than 1.1, liver enzymes, elevation of liver enzymes 2x times, okay, and pulmonary edema, pulmonary edema. Fourth one is visual symptoms, and one more is low platelet count, thrombocytopenia. If you see these symptoms in any case of gestational hypertension, then you are not going to call it as gestational hypertension. Immediately the diagnosis will get changed to pre-eclampsia. Okay, once if you see in PIH case, once if you see end organ damage or proteinuria, it is called as pre-eclampsia. Now you are no more going to call it as gestational hypertension. And in same preeclampsia case, if she throws scissors, it becomes eclampsia. I've already told you, right? No confusions. All right, coming to the present topic. I told you, right? PIH with severe features, that is end organ damage and proteinuria, you call it as preeclampsia. In same preeclampsia client, if she throws scissors, you are going to call it as eclampsia, right? So in eclampsia, you are going to see seizures. Yes, obviously marked proteinuria. That's an end organ damage symptom. It's automatically involved in this preeclampsia. Yes, BB will be greater than 160 by 110 mm of Hg. The one which we didn't discuss is mild facial edema, right? Mild facial edema is not that, it's wrong option here. Option C is, as you people said, option C is right. Okay. Now tell me, what is the drug of choice for eclampsia? I've already, yes, you people already told me that it is magnesium sulfate. Tell me, what is the loading dose of magnesium sulfate? Very, very important. I think this is very repeatedly asked MCQ, very important. I want all of you to prepare notes on this. What is the loading dose of magnesium sulfate? Yes, what is the loading dose of magnesium? Here I am okay, loading dose, and you will have maintenance dose. Loading dose, total loading dose is total loading dose. No confusions, my dears. Total loading dose is 14 grams. 14 grams. And in this 14 grams may 4 grams you will give in IV route, in 20% dilution you will give. That means 4 grams of magnesium sulfate you are going to take, plus you are going to add 12 ml of normal saline. You will make a 20 ml solution and give slow IV. Okay, whereas here 10 grams you will give each 5 grams in each buttock. Each 5 grams in each buttock. So this becomes 14 grams of loading dose. 14. So total loading dose in Pritchard regime, just now which I am discussing is Pritchard regime. Pritchard regime, magnesium sulfate loading dose is 14 grams. Grams, it is not mg, 14 grams. So those who have answered it as 14 milligrams, you people are right. Sorry, you people are wrong. See, one magnesium sulfate ampule has 2 ml in it. ఒక్క MgSO4 ampule లో 2 ml ఉంటుంది. 1 ml is 500 mg. So 2 ml becomes 100 mg. Sorry, 1000 mg or 1 gram. You can also call it as 1 gram. So total loading dose is 14 grams. That means 14 grams you need to give. That means how much? How many ampules you are going to take? So each magnesium sulfate ampule contains 2 ml. 1 ml contains 500 mg. 2 ml is 1 gram. Okay, and in loading dose it is 14 grams you are going to give it to the mother. 4 grams you will give IV in 20:2 dilution. How you will make 20:2 dilution this magnesium sulfate is, you will take 4 grams of magnesium sulfate, that is 8 ml of magnesium sulfate you will take, you will mix it in 12 ml of NS and you will give slow IV, okay, and then 10 grams of remaining magnesium sulfate in this loading dose you will give each 5 grams in each buttock undiluted. Here you will not dilute it with normal saline, you will directly give it into the muzzle, okay. And maintenance dose is, how much maintenance dose you are going to give? Maintenance dose is 5 grams each, 5 grams in alternate buttock you will give every 4th hourly. Q4th hourly you need to give maintenance dose 5 grams in alternate buttock you will give. IM, intramuscularly you will give undiluted. Even maintenance doses you will not mix it with normal saline, you will give directly into the muzzle, alternate buttocks every 4th hourly maintenance dose need to be given. And very important, before giving maintenance dose, I want all of you as a nursing officer, you are going to administer magnesium sulfate to the client, and before giving maintenance doses to the this pregnant lady, you need to monitor this important 3 things you need to monitor. What are these 3 things? Can you people tell me? This should be on your fingertips. You should never forget about this when you are taking magnesium sulfate into your hand. This should come into your mind. The next second you need to think about this. Yes, before giving maintenance dose, as a nursing officer, always check for, okay, always you will check for DTR. What is DTR? Deep tendon reflexes. You will check the patellar reflexes. Take the knee armor, check the patellar reflex. If the patellar reflex is absent, then you will not administer the maintenance dose. You will withhold the maintenance dose, and then again after 4 hours you will wait, and again after 4 hours you will check the DTR, and if it is present only then you are going to administer the maintenance dose, right? So if the maintenance dose is absent, DTR is absent, or if the respiratory rate is less than 12 breaths, less than 12 breaths per minute, or if your urine output is less than 100 ml in 4 hours, you will not give the maintenance dose, you will withhold the maintenance dose. Withhold MGS4. You will not give the maintenance dose. Okay, since the doctor have written the instruction, give maintenance doses after 4 hours. No, you need to check for DTR whether it is absent or not. If it is present only, then you are going to administer the magnesium sulfate. You also will check the respiratory rate. You also will check the urine output. Okay, so DTR must be present. Respiratory rate should be greater than or equal to 12 breaths per minute, and urine output should be greater than or equal to 100 ml in 4 hours. Then only you are going to administer the maintenance dose of magnesium sulfate in that eclampsia patient. So this intavaraku nenu edaithe cheppano, this is called as Pritchard regime. Okay, Pritchard regimen, which is followed for this magnesium sulfate in case of eclampsia clients, right? I want all of you to, this Pritchard regimen should be on your fingertips. Don't answer it as milligrams. Again I am telling you, most of you people will tend to do these mistakes. So tomorrow in exam they'll give you what is the loading dose of magnesium sulfate. Option A 14 mg, option B 14 grams. So you people will definitely confuse. So most of you people are giving now as 14 mg. 14 mg is, it's a blunder. Okay, 14 mg, don't answer it as, don't answer. Okay, 14 grams. 1 ampule contains 1 gram. So 14 grams of loading dose you are going to give. It is grams. Okay, right. 14 grams or 14,000 mg you are going to give. Okay, it is not 14 mg, it is 14,000 mg. See how much variation is there with your answer. Right, I think I have completed with my today's class. Okay. So I'll share this PPT. I'll share this slides on my Telegram channel with the same name called Medsee Nursing. Go download the printout and you can have this for your exam. And I think you people got benefited with my this session. So if you have liked the session, kindly do subscribe to my channel. Do comment for your what topics you needed for my forthcoming classes. So I'll plan accordingly. Thank you all for your patience, my dears, and see you all in see you all very soon in one more live session. Until then, stay tuned and good night.